Hello, everyone, and welcome to our podcast. I'm your host, Dr. Harshita, and today we are privileged to have with us Dr. Nataraj Naidu, an esteemed expert in surgical oncology based in Bangalore. He has more than a decade of expertise and experience in the field of oncosurgery. And today, Dr. Nataraj brings a wealth of experience and expertise to our discussion today. Welcome, Dr. Nataraj. It's a pleasure to have you here.
Good afternoon.
Thank you. So, doctor, let's begin. How is early stage breast cancer typically diagnosed, and what diagnostic tests are commonly used in the process?
As we all know, breast cancer is the second most common cancer in the world, but in India, it is the first common cancer among females. This is due to the various testings that have been happening. It's due to the health education, the screening process, and awareness. So we are identifying the breast cancer in early stage. So early breast cancers are identified. So based on the early identification, we are treating them. So though there is an increase in the incidence of breast cancer, so the mortality associated with breast cancers have reduced. This is because we are treating the cancer early and we are giving a curative treatment. So the different ways of identifying early breast cancer is basically the screening. So screening that happens when there are no symptoms, and second is when patient presents with symptoms to the hospital. So some of the symptoms being lump in the breast, or finding a small discharge in the nipple, or going for a regular health checkup. When patient presents with these complaints, the clinical examination that the doctor does, following which the mammography that is being done and ultrasound breast and axilla, these help in identifying the breast cancer early. In young females who are less than 40-year-old, so mammogram may not be a useful tool in identifying the breast cancer. In these females, ultrasound breast as well as MRI breast, they play a major role in identifying the breast cancer at an early stage. Now, with the awareness about the breast cancer, we are suggesting something called as a self-breast examination from the age of 20 years. So that is also helped us in identifying the breast cancer at an early stage in younger females. Almost a decade before, the percentage of breast cancer in females less than 40 years was about less than 5%. But this incidence has increased drastically over the last 10 years. So early awareness about the breast cancer, self-breast examination, every 6 months clinical breast examination by a professional. Along with that, the tools like mammography, ultrasound breast, and MRI. All these help in identifying the breast cancer at the early stage. Why we want to identify the early breast cancer? See, if you are able to identify the breast cancer at early stage, the most important thing is the self-esteem in female can be preserved. We can give a better quality of life. We can cure the disease, and we can prevent the recurrence as well as the complications associated with other treatments that may be required if they are diagnosed at a later stage.
Yes, rightly said, doctor, and it's crucial to the diagnostic process for early intervention. And now, I want to know the primary treatment options available for managing early breast cancer.
Early breast cancers. So there is a staging system for early breast cancer, wherein something called as a stage 0, stage 1, and stage 2A. This is called as a TNM staging system. So this is universally used all over the world. So based on this staging system, so initial stage 0 to stage 2A is considered as early breast cancer. So we already discussed about what are the screening tools that may be used in identification of this early breast cancer. So once you identify there is a lump, then we do the diagnostic test like biopsy, something called as a core biopsy, where we get the tissue from the breast lump and we do something called as a staging system. Staging is done with the help of either an ultrasound abdomen, CT chest or CT abdomen, And bone scan, if you find any symptomatic patients with symptoms suggestive of backache and all, or if their blood test suggests there is a raised alkaline phosphatase, so wherein a bone scan may be required. Once we do this diagnosis of carcinoma breast with the biopsy and staging, we do something called as a immunohistochemistry testing. So in immunohistochemistry, we look into the specific estrogen receptors, progesterone receptors, HER2 receptors, and Ki67. These play a major role in the management of breast cancer. These help in dividing the breast cancer into further subtypes, wherein our treatment aspect also will change. So if you take stage 0, so most of our treatment goes by either the stage of the disease or the subtype of the breast cancer. So as we all know, there is the most common or the curative modality of treatment is surgery. Previously, we used to have radical surgeries wherein the entire breast along with the axillary lymph nodes, we had to remove it. So with the time, we have evolved in such a way that we are doing now something called as a breast conservation surgery. Along with that, if you are doing a breast conservation surgery, our main aim is to remove the local disease with the help of surgery, followed by preventing the local recurrence with the help of radiotherapy and preventing the systemic recurrence with the help of chemotherapy. So the surgical procedures like mastectomy as well as the breast conservation surgery, these can be planned based on all these reports. We have done the subtypes of breast cancer, wherein there is estrogen receptor positive tumors, progesterone receptor positive tumors, but HER2 receptor is negative and Ki67 is low. This is an ideal candidate for surgery. So in these patients, based on the size of the tumor compared to the breast, we offer the treatment regimen to the patient. It is not a fixed treatment to the patient. So it is at the choice of the patient, but we have to take care of the international guidelines that have been followed. So the results can be comparable with the other treatment modalities that are being given. So in surgery, the most common that is done at present is breast conservation surgery. It accounts for about 80% of the cases, and remaining 20% we offer something called as a total mastectomy.
Yes, and doctor, could you also shed light on adjuvant therapy and how does it complement surgical treatment in early breast cancer management?
As I already started with it, so there are 3 stages called as the stage 0, stage 1 and stage 2A. Most commonly in stage 2A, wherein a lymph node is positive, chemotherapy will be used as an adjuvant therapy in that. In a patient who is stage 0, there are few diseases like DCIS, that is ductal carcinoma in situ, wherein that it is a precancerous condition wherein the tumor has developed but is not infiltrated into something called as a basement membrane. So it is not spreading to the other parts of the body. So in these cases, when we do surgery as a modality of treatment, post surgery, we give adjuvant hormonal therapy, either in the form of tamoxifen or in the form of aromatase inhibitor, based on whether patient is premenopausal or postmenopausal. That is with stage 0. When it comes to stage 1, where the tumor size is less than 2 centimeters, and when the estrogen receptor, progesterone receptors are positive and HER2 is negative, these are, and Ki67 is low, these are the candidates for only hormonal therapy. But in case of stage 1 and stage 2 diseases, where ER/PR are negative and HER2 is positive and Ki67 is on a higher side, in these patients we need to give chemotherapy as an adjuvant treatment, and if it is Herceptin, based on the Herceptin whether it is positive or negative, we have to see whether the targeted therapy, trastuzumab, can be added as an adjuvant therapy. So nowadays what is followed is we give Herceptin along with our chemotherapy as a neoadjuvant setting in any patient with tumor more than 1 centimeter and it is ER/PR negative and HER2 positive cases, so that it takes control of the systemic spread also. And once a particular cycles of chemotherapy is done, then we'll go for the surgical removal of that area of the breast that is affected, following which we continue the Herceptin for a period of almost 1 year, so that there is no recurrence of the disease. Because in tumors which are HER2 positive, they are very aggressive and there is high chances of recurrence. And there is one more component called as a triple negative breast cancer. In triple negative breast cancer, neither the hormonal therapy nor the trastuzumab or the targeted therapy works. So the only component in this will be a chemotherapy. So when you are giving chemotherapy, along with chemotherapy, nowadays we are planning to add something called as a immunotherapy, so that we get good results. So these chemotherapy, immunotherapy and targeted therapy, they are mainly targeted for the breast cancer to avoid the systemic recurrence. To avoid the local recurrence, any tumor that is more than 5 centimeter, or that we are doing a breast conservation surgery, or we find a lymph node in the axilla which is more than 2, or with extranodal extension, or with high risk factors like high grade tumors and high risk pathological features, the tumor showing the lymph nodal invasion as well as vascular invasion. These are the factors that suggest us to give local radiotherapy. So combining a breast conservation surgery with local radiotherapy and required either chemo or targeted or hormonal therapy will help us in controlling the tumor from recurrence.
Yeah, great, doctor. And now, what are some common side effects associated with various treatment modalities for early breast cancer, and how are they managed?
If you take surgical thing, so side effects are if you are dividing it in patient who are undergoing the surgery, in patient who are undergoing radiotherapy, and patient who are undergoing chemotherapy. In patient who are undergoing the surgery, common side effect will be either local infection, redness in that area, and lymphangitis on the arm on the side where the operation is done. Sometimes they will develop something called as a lymphedema. Most of these things are easily manageable with the help of either stockings or with the help of antibiotics if there is an infection. The main thing we tell a patient who undergo breast surgeries is to avoid any type of injury to the arm on the side of surgery, or getting any blood drawn, getting the BP checked, or getting a IV cannula done. So if anything is done, they will have a chance of developing lymphangitis and lymphedema. So that is related to the surgical part. When it comes to the radiological part, when radiotherapy is done, there are few changes. If you're taking around 3 decades before, most of the people who underwent radiotherapy, they used to have their skin used to get burnt, discoloration of the skin used to happen. There used to be a lot of lung fibrosis on the side of radiotherapy, and even it is to have effect on the heart if the surgery or the radiotherapy has happened on the left side. With the newer techniques of radiotherapy, most of the side effects of radiotherapy have come down. So the skin reaction is mild to minimal. The redness has gone. The only thing will be patient, sometimes they develop lymphedema and there will be mild pulmonary fibrosis may happen based on the response of the individual to the radiotherapy. When it comes to chemotherapy, in chemotherapy it is called as the acute, it is called as the subacute and the chronic ones. Means immediately after the chemotherapy, the commonest side effect they develop is either a nausea, vomiting or loose stools. This will be related to the gastrointestinal tract. That is the commonest thing that you have seen. Other than that, they will have little bone marrow suppression. So initial period of their chemotherapy, let us suppose they add the chemotherapy on day 1, their counts will go down on day 3. So they will have the chances of getting infected in the first 1 week. If care is taken during the first 1 week, the chances of infection will be nullified. So commonly we use some of the medication that helps in the developing the growth factors. So we'll get back the WBCs which help in fighting against the immunity. So there are various drugs that are used along with chemotherapy to prevent this. So other commonest side effect, and it is as a social stigma, is hair loss. So females are usually concerned that once chemotherapy started, I will develop hair loss and I will develop other issues. But hair loss is temporary and it is associated with only few of the type of chemotherapy. But this hair loss, the hair comes back after a period of almost 6 weeks to 6 months based on individual. So once the chemotherapy is stopped, by the end of 6 months, they will get their hair back. So there are other major complications are usually well managed with chemotherapy drugs and supportive drugs. So any female with early breast cancer with surgery and radiotherapy being done, chemotherapy will add it to avoid the distant metastasis, but side effects are manageable, wherein we are not using so high toxic drugs in the early breast cancer. And we are moving more towards the targeted therapies, thereby the complications associated with the chemotherapies will be less.
Fascinating. Now, Doctor, as we wrap this insightful conversation, could you share your key takeaway message for our listeners?
See, there is a shift in management of breast cancer, that to early breast cancer, over the past 2 to 3 decades. So previously, we used to do radical surgeries that used to be so much of effect on the patient rather than the physical effect. It used to cause their self-esteem to come low. So the quality of life also would have go low with this. So our treatment at present with early breast cancer is more of a patient-centric treatment. So your first point of contact should be either a breast surgeon, a surgical oncologist, or a medical oncologist, wherein evaluation of the lump, it shouldn't be delayed. The minimum biopsy to be done should be a core biopsy or true cut biopsy. Wait for the results to come so that a proper treatment can be planned. Get oneself educated about the disease before going into any type of treatment, and trust your doctor that a proper care will be given. So with this, once the diagnosis is done, the staging is done, and subtype analysis of the breast cancer is done, then a proper treatment can be given either in terms of a breast conservation surgery. If we ask, in India, almost there is 60 to 80% transition from a total mastectomy to a breast conservation surgery in India. And in Bangalore, is almost 80 to 90% of the patients, they go for a breast conservation surgery, irrespective of the stage of the cancer. So we, as a surgical oncologist, we support the patient so that their self-esteem is very well maintained. So, and once the treatment is done, they go out with a positive outlook so that they can give message to the others, their friends or the society, saying that one shouldn't be scared about breast cancer, the word cancer, so that a proper treatment, a curative treatment can be done in them.
Thank you, Dr. Nataraj, for sharing your invaluable insights into the management of early breast cancer. It's been an enlightening discussion, and I'm sure our listeners have gained a wealth of knowledge. That wraps up our insightful conversation today. Once again, thank you so much for joining us, Dr. Nataraj.
Thank you.
And to our esteemed audience, thank you for tuning in. Before we say goodbye, I encourage all healthcare professionals to explore the enriching opportunities available on our MedSynapse platform. It's a unique space where you can engage in meaningful discussions, connect with esteemed medical professionals, and contribute to the continual progress of healthcare. Stay informed, stay healthy, and until next time, take care. Goodbye.